bonjour. Merci de nous laisser la possibilité de présenter aujourd'hui.
Hello, thank you very much. We are very happy to be able to show you the results for these patients with cervical or breast cancer during this study in Bamako. Now, cancer has become a major public health problem, and so we think that the incidence could be multiplied by as high as 3, according to WHO. The two major cases in this population are cervical cancer and breast cancer. Survival rate is very limited, as reported by Dr. C.D. Bay in a study in 2015, and it's around 13%, probably because of limited access to early diagnosis and also the lack of effective treatments, and the majority of women are treated in Bamako. Since 2018, MSF has been supporting the MOH in Mali in order to control or to improve cancer treatment with palliative care, and then as early as 2020, cancer screening and diagnosis and curative and palliative treatment offered by MSF. Then MSF rehabilitated and modernized the pathology laboratory at the teaching hospital. And we created a liaison cancer support team or support unit. And we decided also to start a study to improve the screening and management of these women with the overall aim of assessing the global survival, and secondary endpoints were to describe the social and demographic and clinical characteristics of the cohorts and estimate survival at 1, 2, and 3 years, and also describe the risk factors associated with mortality. Now, the overall survival likelihood is based on a retrospective analysis of these patients between 2019 and December 2022 with MSF support, and treated in one of the 3 teaching hospitals in Bamako, which are the main reference centers in Mali. Data were collected retrospectively by oncologists on the basis of questionnaires. The survival at 1, 2, and 3 years for each type of cancer was assessed according to Kaplan-Meier curves and assessed with a log-rank test. The risk factors for mortality were assessed according to Cox regression. Multiple imputation for missing data was taken into account. Survival and treatment was assessed in patients with an advanced stage. So we looked at the mean survival time after selection, and the date of cancer and the pathology date. We included several hundreds of patients for cervical cancer and breast cancer. You can read the number of patients on the screen. Now, stage 3 for 75 patients, and at the end of follow-up, 31.9% of patients had been lost to follow-up. The number of diagnosed women went from 21 in 2019 to 169 in 2022. The proportion of women with this cervical cancer early diagnosis was multiplied by 2. Treatment, 48.4% of women were treated with chemotherapy, 4.4% combined with radiation therapy, 20% only benefited from support care, 7.6% surgery, and 19.1% chemotherapy combined with surgery. First important result, first important outcome, the OS at 1, 2, and 3 years was respectively 88%, 70%, and 55%.
En analyse ajustée,
Now, the adjusted analysis gives us a risk of death of 53% for the early stage cancer at the time of diagnosis versus advanced stage. With regard to the results following the treatment I'm going to tell you about, well, this is only for women with an advanced stage at the time of diagnosis. After a 3-year follow-up, patients treated with chemotherapy only showed an average survival, non-statistically significant, 4.5 months versus women with support care only. Likewise, patients treated with surgery only showed a longer survival rate of plus 2.5 months, non-statistically significant, versus the women treated with support care only. At 3 years, patients treated with chemo and surgery had a significant gain of more than 10 months versus support care only. And therefore, after a 3-year follow-up, these patients treated with chemoradiotherapy were benefited of 10.5 months more versus support care women. With regard to breast cancer, the median age at diagnosis time was 47. 77.1% of women presented with stage 3 at the time of diagnosis. At the end of follow-up, 29.8% of patients were lost to follow-up. The number of women diagnosed went up from 40 to 268 in 2022. The proportion with early stage was multiplied by 2. The molecular type, 23.6% were triple negative. However, considering that if we look at the IHC without the missing data, we can say that 44.5% of tumors were triple negative. With regard to treatment, 39.3% had chemo only, chemo and surgery 42.7%, 8% were support care only, 3.5% surgery only, and 42.7% chemo plus surgery, and 6.4% chemo plus surgery and radiotherapy. Hormone therapy was given in only 8% of cases. However, if we consider those that are responsive, 77% of women received hormone therapy and were indicated for it. The OS at 1, 2, and 3 years was respectively 91, 80, and 72%. The adjusted analysis gives us a lower risk death by 43% in early stage women versus advanced stage women.
Alors, les résultats concernant le traitement que je vais vous présenter
là, the results of treatment concern only women with an advanced stage at the time of diagnosis. After a 3-year follow-up period, patients treated with chemo only showed an average survival non-significant of 2.5 months versus support care only. Likewise, patients with surgery in the surgery-only group had 7 months more, non-statistically significant versus support care women. And furthermore, at 3 years, patients treated with chemo and surgery showed a statistically significally gain of more than 9 months versus women in the support care group. And also, patients treated with chemo, surgery, and radiation therapy showed a significant gain, statistically significant of 12 months versus support care only. Now, we could see with the outcomes that there are some limitations with this study, some epidemiological limitations. So there are some missing data because this is a retrospective study based on patients' records scattered across different centers. There's also quite a high number of loss to follow-ups because these patients are treated in a centralized manner in Bamako, irrespective of where they live, and quite a number of them live outside Bamako, and it is also impossible to have the figure for the overall survival without progression, survival without progression. Some are so advanced that they couldn't be treated with surgery. There's also, in some cases, very limited access to radiation therapy. Only 4% of women, for instance, in cervical cancer could be treated that way, though it is the cornerstone of treatment for advanced stage. Also, very few patients were treated with immunotherapy. Maybe in the missing data of histochemistry, immunohistochemistry, there could have been a higher proportion of patients with hormone-dependent cancer. So despite these limitations, there is a high survival compared to literature. Now, of course, there are some positive factors to explain for these results. Free access is one. Also, the fact that it is a multidisciplinary approach. There was an MDT meeting for each case, and also when chemo and radiation therapy was not available, some of these women could be treated with chemo and then surgery with apparently results that are more or less on par, and they could also benefit from the individual support, so that these women were not, at a loss to know where to go when they have to switch between chemo, surgery, radiotherapy, and the benefits from support care is higher than expected, and the fact that all women could be taken care of by this support care contributed to the survival. David could show that the management at an early stage increased between 2019 and 2022 following support given by MSF for screening. So we need to continue to improve early diagnosis. So in order to do so, we need to improve the training of healthcare professionals involved in that, and we could show that a multidisciplinary approach, even for advanced stage cancer, can improve survival. We need to improve the immunochemistry screening. We need also to look into the genetic factors to account for the high proportion of triple negative forms in Africa. Could it be that we could have HPV screening improving the diagnosis, and following up this cohort will give us more data on long-term follow-up in Africa, which is often missing, and to see also the impact on quality of life. This study highlights the feasibility of treating patients with cancer in LMIC countries, and the feasibility of all the different actions we put in place. I'd like to thank the MSF teams and the co-investigators.